introduction, Austin. We'll continue. All right. Just to recap, my name is Antony. I'm one of the students from Rutgers, New Jersey Medical School, and I'm going to start off the talk tonight by discussing a little bit about what uterine fibroids are and how they're treated before we get into the trials. So what are uterine fibroids? They can also be called leiomyomas or myomas, and they are the most common pelvic tumor found in women. The technical definition is a benign neoplastic proliferation of smooth muscle, and that arises out of the myometrium of the uterus. So fibroids are actually very common. It most often occurs in women aged 20 to 40. There's this study published in the American Journal of Obstetric Gynecology that found up to 51% of premenopausal women showed some evidence of fibroids. So that doesn't mean these women were symptomatic, but they are very prevalent. And this study also did some calculations to estimate a really high cumulative incidence of fibroids, as high as 80% in African-American women and 70% in white women by the age of 50. So this is, a condition that affects a very large population, and it's important to know about how these women present and what we can do to help them. So another aspect that's important to understand about fibroids is that they respond to estrogen. So the more estrogen exposure a woman has throughout her lifetime, that correlates with increased growth. And that explains why the peak incidence occurs in the age range that it does. In these premenopausal years after menarche, there's high levels of estrogen exposure, so that leads to growth. This is also an important thing to take note of, if you're considering some of the treatment options that we'll get to. But for example, if you do a myomectomy and you don't take out the full fibroid, there's a chance it may come back because there's continued estrogen exposure and they will continue to grow. So some risk factors for fibroids to be aware of. They're most common in African-American women. African-American women also seem to become symptomatic at a younger age. And another population to be aware of is Hispanic women. For whatever reason, fibroids seem to be more prevalent and cause more problems for these patients. Other risk factors you can see on the screen here are nulliparity, early menarche, obviously that makes sense, earlier exposure to estrogen cycles. Obesity can predispose you to certain conditions like PCOS, where you may have abnormal levels of estrogen, and there are some studies that have linked early onset fibroids and symptomatic fibroids in patients who are exposed to hormones therapy in utero. So let's talk through some anatomy here. If you guys can all see my mouse on the screen, obviously we're looking at the uterus, fallopian tubes, ovaries. Important to note here, we have our myometrium and the inner lining of the uterus, the endometrial lining, right? So there are different types of fibroids. You can all read on the screen here, but they can be intramural, they can be subserosal, which are poking out of the outer layer of the uterus. They can push in onto the endometrial layer with submucosal fibroids. Some fibroids also have these pedunculated stalks where they can come off the lining of the uterus. So they can present in many different ways, and certain subtypes are associated with different symptoms, but just important to be aware of the different types. Continuing with the anatomy theme, for the blood supply to the uterus, we have the ovarian arteries up here that are coming off of the aorta, just under the renal arteries. And they supply the fallopian tubes, the ovaries, and they anastomose with the uterine artery up here. But what is important for us is the uterine artery here. All the fibroids that I previously mentioned will be supplied by these uterine arteries. Another thing to take note of is uterine artery that comes off the internal iliac. You have to be careful when selecting this artery so that you're not coming into some of these cervicovaginal branches, because if you embolize those, you're going to cause necrosis to tissue that will have no effect on the fibroid itself, and that can be very detrimental for patients. All right, so how do these patients present? Obviously, the one we might all be aware of is heavy menstrual bleeding. The presence of fibroids can cause menstrual cycles to be heavy, flows to last longer, and this can, lead to such a severe level of blood loss that it can cause iron deficiency anemia. So when you're encountering a patient, assessing a patient, you really want to get a thorough gynecological history, understand their menstrual cycles, how frequently are they having their periods, how long do they last, how heavy is their flow. You want to ask very specific questions as well, like, how many pads or sorry, can you stop that? You want to ask about how many pads or tampons they're using. And some women may have such heavy flow that they just skip that altogether and will use diapers, or they'll stay at home during their periods because they're afraid of, showing in public. So one thing I want to emphasize here with regards to the menstrual history, many women, other women in their family may have very similar signs of bleeding, so they may think that their menstrual flow is normal. They may not even be aware that this is a potential problem. So that's why getting an accurate history is very important. Moving on to signs of anemia, this is another way patients can present where, what are some of the signs of anemia? You can have shortness of breath, you can have dizziness, fatigue. These are all like very common symptoms that patients may brush off and may not think is a big deal, but are clues to clue you into a bigger problem at hand. All right, so when fibroids eventually grow to be big enough, they can cause bulk symptoms. So these bulk symptoms are anything that you can imagine within the pelvic cavity that the fibroid and the uterus is now impinging on or pressing on. So for example, if you're thinking about the surrounding structures anatomically in the area, if you're compressing the bladder, these patients may present with frequency, or the fibroid may be actually obstructing the ureter, and this, somebody presents with hydronephrosis. Other problems include early satiety, pelvic pain and pressure. This is another big one. So some patients with large enough posterior fibroids can actually have low back pain as their only complaint. And, low back pain is extremely common. So it's just, I'm just trying to get the point across here that the history is important. Trying to clue all these symptoms together is important. Other ones to be aware of: fibroids can lead to infertility, venous compression. If the fibroid's big enough, it can compress the IVC and your patient may present with DVTs. This is a little less common, but it's possible. And things like dyspareunia. Sometimes fibroids can even prolapse through the uterus depending on what type of fibroid and where they are. And fibroids can also increase the risk of pregnancy complications. All right, so we talked a little bit about the history. Now let's talk about diagnosis. We actually find out that our patient has fibroids. So the first optimal, cheapest, best screening tool is ultrasound. One second. There we go. So for ultrasound, it's a great screening tool because it's quick, it's easy, it's efficient, and you can see that the fibroid is there. And once you establish the diagnosis, once you know the patient has fibroids and you want to think about further planning options for treatment, the next best step is MRI. MRI really enables you to characterize the fibroid, and it can also give you more information you might not be able to get on ultrasound, like how many there are, how large they are, where they're located. And all of this comes into play to, optimally decide on the treatment option for our patients. Also of note, some some operators like to get an MR angiogram to better characterize the blood vessels that are supplying the uterus and see if there's any collaterals or weird vascular anomalies, just to be aware of procedurally, but this isn't commonly done. Okay, so moving on to management. We've now established our diagnosis. We know our patient has fibroids, and we want to think about how we can characterize them. So if your patient is in the mild symptoms category, gynecologists will often prescribe medical therapy. Medical therapy is mostly hormonal management. Oral contraceptives are popular. However, side effects are frequently not well tolerated by patients, and unfortunately, the medical therapy doesn't really do well for patients that find themselves in the moderate to severe category. They just don't work well enough, and more drastic measures need to be taken. So when we find ourselves in the moderate to severe category, we enter some of the treatment options you can see here. And mainly it's surgical versus uterine artery embolization at this point. The surgical category, we have hysterectomy, which is taking out the whole uterus, fibroids and everything. Myomectomy, which is just selecting the fibroid, cutting that out, keep the uterus in, or uterine artery embolization, which is causing infarct to the fibroid, and that is also a uterine sparing procedure. There's also endometrial ablation for certain submucosal fibroids, and if there's only one, for example, one or two, this may be an option, but more so we find ourselves considering surgery or uterine artery embolization. At this stage, I want to stress the importance of a collaborative effort between interventional radiologists and gynecologists. Patients should be seeing both. They should be being offered all of these treatment options, and ultimately it should be, come down to the decision of patients. What do they prefer? Do they want major surgery? Do they want to keep their uterus or not? So once we make that choice, and let's say we decide on uterine artery embolization, it's important to keep in mind some absolute contraindications. So obviously, if there's a current pregnancy, you're not going to continue with the embolization. So always provide a pregnancy test for your patients. Another big one is gynecological malignancy. So all of our patients will get a pap smear and as well as a workup from a gynecologist to rule out cancer and make sure, we're not treating the wrong thing here. Some other things to be aware of is allergy to contrast, coagulopathy, and renal failure. All right, so getting to uterine artery embolization itself. The first uterine artery embolization that was reported happened in the late 70s out of UCLA, where interventionalists embolized the uterine arteries in a patient that had a really bad postpartum hemorrhage. And they realized at the time that it was an effective method to stop the bleed. Fast forward 25 years, and the first publication came out of uterine artery embolization for the purpose of fibroids. This study came out of Paris, and 1 year later, there was a report coming out of the US. So this is a relatively new procedure as far as fibroid treatment goes, but as you'll see with some of our studies later on, it is really effective and an excellent option to provide our patients. So the procedure itself, vascular access, is very straightforward. You can either go radial or femoral, depending on operator preference. And then I wanted to talk a little bit about unilateral versus bilateral embolization. In the beginning, in the early years of this treatment option, there are certain operators that would only embolize one side. And as you can see in the picture down here, fibroids are almost always supplied by both uterine arteries. So if you only did one side, it would be an incomplete infarct of the fibroid. They would still have plenty of blood supply, and that won't solve the problem for our patients. So these days, every patient gets bilateral uterine artery embolization. Another important thing to note is we're not completely cutting off the supply to the uterus. So what interventional radiologists do is they embolize to 5-beat stasis, which essentially is seeing sluggish flow in the uterine artery for up to 5 heartbeats. So what this does is ensure that there's enough embolization to infarct the actual fibroid itself, but there's still enough flow that will preserve the uterus and not cause, any undesired effects that way. Finally, important to note is post-embolization syndrome. So patients will have transient fevers, pain, nausea after the procedure. This is normal. This is expected. This isn't, a complication. It is just, a normal post-procedural course. So women can have severe pain up to around 24 to 72 hours after the procedure. This is expected. This should be explained ahead of time. The patient should know this is coming. And some things that we do to help mitigate and alleviate that pain is so intra-procedurally at the end of the procedure when both arteries are embolized. I know at our institution at Rutgers, Dr. Kumar and Dr. Shulkla will inject intra-arterial lidocaine and give IV Tylenol. That's immediately post-procedure. And then after that, for the first 3 days, it's important to have an appropriate pain management schedule. So oral narcotics for the first 3 days are completely normal and expected, and we'll make sure, we get our patients through this post-embolization syndrome. Also to note, this isn't so bad that, patients need to stay hospitalized. These patients, they come in the morning, they're home by the afternoon. So this is totally, normal, manageable, just something to be aware of. Another thing I wanted to note of interest. So I mentioned our institution, we do lidocaine and IV Tylenol. Some operators across the country have been publishing recently about hypogastric nerve blocks, and there's some evidence to support that also helps with the pain post-procedurally. And here is just an angiogram before and after. So you can see on the left, there's flow to the uterus and fibroid. And over here, bilateral uterine arteries have been embolized and the blush is no longer there. These are my citations. Thank you. And I'll pass it on to Shrin, who will be discussing the EMMY trial.
Perfect. Okay, so before we dive into the EMMY trial, I wanted to thank Anthony for giving us a great overview of the pathophysiology and management options for fibroids. The first trial we're going to take a look at today is the EMMY trial. The EMMY trial 10-year data was published in 2016. The study itself took place early 2000s. And one of the reasons it is a landmark trial in the field of fibroids is because of this lengthy follow-up period, which gives us a glimpse into some of the long-term outcomes following UFI and following hysterectomy. Okay, next slide. Oh, next slide. Okay, so this study is a large multi-center randomized controlled trial. Wait, this slide before that, sorry. And it was done in the Netherlands with 177 patients, and it was designed as a non-inferiority study. And the goal of such a trial is to determine whether uterine artery embolization is non-inferior to hysterectomy when it comes to relieving fibroid symptoms. So these kinds of studies are done when it's not possible to have a placebo group, or when it would be unethical to withhold treatment, or when a really large sample size is required in order to show superiority of one treatment over the other. The way the study authors demonstrate this is by stating a non-inferiority margin, and this is the amount of difference between the two treatments that is considered tolerable for the new treatment to be considered not worse than the original. In our case, this is the rate of secondary hysterectomy in the uterine artery embolization group during the study periods that the authors are willing to accept. So in this case, they set it to 25%. So in other words, their main hypothesis that they're testing is that less than 25% of patients assigned to the UFI group would have a hysterectomy during this study period. So based on this hypothesis, a power analysis was done to determine an adequate sample size. What's important to note is that this power analysis was done with respect to this specific hypothesis. Later on, when we look at the other aspects of the study, we see that they compare other variables between the two treatment groups, but because the power analysis was only done for the reintervention rate, we don't really know if the study was adequately powered enough to reach conclusions on the other aspects. So based on the power analysis, the sample size was determined to be at least 60 patients. In reality, they ended up enrolling 88 patients to receive UFI and 89 patients to receive a hysterectomy. And these patients were recruited from around 30 participating hospitals in the Netherlands. Okay, next slide. Okay, taking a closer look at the women who were recruited to the study, we note that all the women in the study were willing to receive a hysterectomy. They had no other viable treatment options other than a hysterectomy, and they had no wish to conceive in the future. This is worth highlighting as a contrast to the FEMME trial that we'll take a look at later, because those women were very different in their inclusion criteria. And as you can see in the table, no huge differences in the demographics between the two treatment groups. And you can see a lot of the symptoms that Antony talked about when he was discussing like the pathophysiology and like clinical presentation of fibroids. Like you see the heavy menstrual bleeding, as well as the anemia that's present in a lot of these patients. Okay, next slide. So this slide takes a look at the characteristics of the fibroids between the two treatment groups, as well as the types of hysterectomies that were performed. So you can see they're pretty comparable, and a lot of the hysterectomies were done abdominally. Okay, next slide. And the way that the long-term outcomes were assessed in the study were through a series of questionnaires that have been independently validated. So there were also questions on whether the patients were satisfied with their primary procedure and whether they would recommend this treatment to a friend. And the same questionnaires were mailed out at various time points. So with any longitudinal study, there's going to be some attrition, and it's very difficult to have perfect follow-up, especially over the course of 10 years, but you can see the response rates on the right. And of the 81 patients that underwent UFI, 63 patients still responded 10 years later, and of the 75 patients that underwent hysterectomy as their primary treatment, 68 responded at the 10-year mark. Okay, next slide. The study outcomes were analyzed according to an intention to treat model. And as we talked about before, it's important to keep in mind that the original power and sample size calculation were based on the reintervention rate. So once again, we don't really have a clear idea of whether the study was adequately powered to detect differences in these other endpoints, such as quality of life, like menopausal symptoms. But in any case, the differences in these other outcomes were assessed with t-test. Next slide. Okay, so now we'll take a closer look at the main outcome, which was reintervention. So of the patients that received UFI, there were 28 total secondary hysterectomies performed. And you can see that the main indication for performing these secondary hysterectomies was inadequate symptom relief. And the majority of them, 19, were performed within the first 2 years. This has been attributed in the study to the high technical failure rate that they saw in their treatment group, which we can touch on later. But I also want to mention that a second embolization was not offered as a reintervention for these patients, so it was only hysterectomy if they had inadequate symptom relief. And it's also worth noting that there were reinterventions that occurred even in the hysterectomy group for various reasons, and you could see those listed on the slide here. Okay, next slide. In terms of other clinical outcomes, there were significant improvements in quality of life in both groups, and scores from the questionnaires remain comparable at all time points. You can see that there were no differences in patient satisfaction at the 5 and 10-year marks between the two groups. This was interesting to note because you would think that there might have been some preconceived preferences when the patients were enrolled in the study, but it was interesting to note that there weren't any big differences in satisfaction, like even if they had to undergo like re-intervention, for example. And next slide. Next slide. And there, from the EMMY trial, there were a few other studies that were published as well. We won't have time today to take a look at all of the data that was collected from this trial, and especially because it was done over such a long time period, there was a lot of different findings. But essentially what the gist was that the UFI patients had more pain relief and were able to return to their daily work sooner than the hysterectomy patients, but there were more hospital readmissions in UFI patients in the initial post-procedure time. So overall, when we look at the results of the EMMY trial, there are some caveats we have to keep in mind. One being the patient selection criteria, and another being the high technical failure rate of the uterine artery embolization that was performed. So as you can see, like in the 5-year follow-up period, in 71.6% of all the women that underwent a UFI, a hysterectomy was avoided. And if you take a look at only the technically successful uterine artery embolizations, a secondary hysterectomy rate was 23.5%. And this is interesting because like the re-intervention rate reported in the EMMY trial was actually much higher than what's been reported in other studies of similar patients. And like we mentioned before, one reason for that could be the patient selection criteria, as in these patients only had hysterectomy as an option, and they were also more willing to undergo a surgical intervention. But what's more important is to mention is the technical failure rate. So a lot of the women underwent a unilateral embolization, and as we mentioned before, most fibroids, or almost all fibroids, get bilateral blood supplies. So this inadequate infarction could lead to the persistence of the symptoms. And one other thing was because the studies, or because the UFIs were done among 30 hospitals and multiple centers had these low UFI volumes, inexperience with UFI and managing these patients was reported as another possibility for the high re-intervention rate. Okay, next. And there's actually a quote from a letter to an editor that's on the slide right there. But this point's kind of been brought up a lot in the literature, especially when it comes to the EMMY trial. And people frequently cite that the inexperience is a possible reason for this high technical failure rate. And so there's another reason we have to be critical about the data that comes of this study. Next slide. So some of the strengths of the EMMY trial, which make it a landmark paper in the field of UFI, include the fact that it was randomized. It did have a large sample size, and with any interventional procedure, it's hard to recruit patients, especially if it's randomized. It can be kind of overwhelming for a patient to know that they may or may not get surgery, for example. But despite the limitations that we've discussed thus far, this data still provides us with a lot of useful information. It also demonstrates the durable effects of uterine artery embolization and its non-inferiority to hysterectomy. So at least, even though the study wasn't designed to demonstrate the superiority of one treatment over the other, it shows that UFI should still be on the table when discussing clinical options for patients, and at least offered, and it can provide similar long-term symptom relief. Next slide. And and as we discussed before, there are several limitations when we're taking a look at this data. One being the power calculation, and another being whether the technical failure rate influenced the ultimate results of the study. And one more point is that in this study, a uterine sparing technique like UFI was compared with hysterectomy. This comes with its own shortcomings because of the inherent differences between the procedures, which is like a good point to end on, I think, because when we come to the FEMME trial, which compares UFI to myomectomy, several different points can be brought up. One of them being like the question of fertility, which was discussed as a big point in the FEMME trial. So on that note, I'll transition to Tushar's segment.
Hi, my name is Tushar. I'm a fifth year medical student at GS Medical College in Mumbai. I'm going to talk about FEMME trial. Thank you, Srina and Antony, for the discussion. Next slide. So FEMME trial basically compared uterine artery embolization versus hysterectomy. And it was done in the UK in 29 centers. They started in around 2013. And the main, next slide. It is a randomized open label trial. The original sample size was 650, which they got from a power calculation. They conducted to get a 90% power using a pilot study, which they conducted in one single hospital, I think at St. George Hospital. But due to the low recruitment rate, they revised their power calculation using the questionnaire results from the FEMME trial, and then they reduced the sample size to 250 patients. The primary analysis the analysis of the primary outcome was performed on an intention to treat principle. Next slide. So the basic clinical question was to examine the outcomes following UFI versus myomectomy, and the primary outcome was health-related quality of life domain of the uterine fibroid symptom quality of life questionnaire. So basically the patients which they considered were females above 18 who had symptomatic fibroids and who were deemed to be treatable by both myomectomy and UFI by interventional radiologist and gynecologist. Then there were some exclusion criterias. These included there should be no adenomyosis, no malignancy. The patient should not have amenorrhea for over a year, no PID, as well as no history of previous UFI or myomectomy. After these, after these criteria were fulfilled, these people were considered for the FEMME trial, and then they were randomized on a one-to-one basis. Next slide. So the intervention basically was the UFI intervention which was described in the protocol was bilateral selective catheterization. So in this, a good point is bilateral embolization of the uterine arteries were done, but there was a drawback, which is the embolic agent. There was no predefined embolic agent, and the embolic agent of choice was dependent on the operator. It just uh, needed to be certified and usable in Europe. Another thing which was an issue was there was no predefined endpoint in the study. In the myomectomy group, the route of procedure, open, laparoscopic, hysteroscopic, was based on the gynecologist, and in some of the patients actually underwent a change from hysteroscopic to open procedure on the table. Uh, Along with myomectomy, the use of GnRH analog or ulipristal was dependent on the operator, and they didn't mention the number of people who received this in the study. Next slide. So the primary outcome which was measured was quality of life uterine fibroid symptom questionnaire at 2 years, and some secondary outcomes included some other validated questionnaires. Then pregnancy, which is an important consideration in this trial, although the results I'll discuss later that the results for pregnancy are not that, like, we can't use them per se, but find a they did find that the number of pregnancy in the UFI group were higher than the myomectomy group, which is a positive point. Then the fertility potential was looked at on the basis of ovarian function reserve using FSH, LH levels at different points during the follow-up. They also looked at the technical success and post-procedure MRI was done for all the patients, although pre-procedure MRI was not done for most of them, but not all of them. And they also looked at serious adverse effects, but they did not categorize the adverse effects. All of them are listed together, and there is no gradation of the adverse effects. Also, post myomectomy and UFI, they looked at the need for further procedures, which I'll discuss. Next slide. So a total of 254 women were enrolled in the trial, 127 in both the groups. In the myomectomy group, 105 ended up undergoing the procedure versus 98 in the UFI group. And the primary outcome, which is the quality of life questionnaire for uterine fibroid symptom, was available only for 81% of the patients, which is after 2 years. Next slide. So important thing to consider in the myomectomy group was 82% of the patients underwent open abdominal myomectomy, which itself is has its associated morbidity as it's an open procedure. And in the hysteroscopic group, all 6 out of the 9 patients had to convert from hysteroscopic to open abdominal procedure. Uh, for the procedure, the length of intervention was shorter for the UFI group, as well as the length of hospitalization was just 2 days for the UFI group versus 4 days for the myomectomy group. There is some discussion about the length being longer in the UFI group because usually patients are not kept overnight everywhere. And uh, after the procedure at 6 months, the post-procedure MRI, only 40% of the patients had complete infarction, which is very low as compared to other published studies, which is a drawback of this study. This could be due to the uh, non-availability of pre-procedure MRIs, as well as different use of different embolic agents. Next slide. So after the intention to treat analysis, the quality of life scores in the myomectomy group were found to be statistically significant and higher versus the UFI group, but there was only a difference of 4 points. And in a complete case analysis, they found an 8-point difference. Next slide. Oh, yeah. Next slide.
Sorry, there's a little bit of a lag between when I hit and when it seems to appear for you guys.
Yeah, that's fine. This is a chart showing the same thing. Important thing to see is in the myomectomy group and the UFI group, there is not a lot of difference. In the there's like a 4-point difference if you, or 80 to 84 uh, if you see the complete cases which were done. And the myomectomy patients with myomectomy group actually had a higher quality of life score when, like, before the procedure. Next slide. Next slide. Oh. Yeah. So
Do you,
after
what slide do you see?
I see the one
Are we good?
like with headline. Yeah. Okay. So
Oh,
after
with
the
headlines.
results,
Okay.
yeah, one. Go back to
Sorry, do you
slides.
need me to go back or go back
Yeah,
a few
go
slides?
back to
Okay.
slides.
Sorry, some technical difficulties.
It's okay.
1 second. Sorry, I got to go all the way through, it looks like. Oh, no.
I'll just keep speaking.
Sure, I'll get there.
Yeah. So after the results of the FEMME trial were published, a lot of publications and news outlets just picked up a point that myomectomy is better than UFI because the quality of life scores showed a significant difference at 2 years. However, it is important to consider that the difference was that the improvement was high in both the groups, as well as the difference between them was not that large, and it could be considered to be clinically non-significant. There are some headlines. The first one is from Interventional News that says FEM trials finds myomectomy improves quality of life more than UAE at 2 years. Another one says myomectomy trumps embolization. And there's a tweet from someone which says quality of life after surgical removal is better at 2 years. However, next slide. So then there are a lot of there is like one letter to the editor which was published in CVIR endovascular, which focuses on the same thing, that even though there is a statistically significant difference, it is unlikely that this will have any clinical relevance, because there is a significant improvement in both the groups, and the difference between them is not that big. Next slide. So next, they also looked at the post-procedure complications, the pregnancy rate, and fibroid-related uh, uh, need for additional procedures. Manus in the manuscript which is published, they do not look at the complications separately. They just look at them as a whole. But in the supplement, in the appendix, in supplementary tables, they actually show all the post-procedure complications. Can you next slide? So when we look at the post-procedure complications in the myomectomy group, the rate for blood transfusion is 10% in the myomectomy group, as well as the rate for major hemorrhage and infections is higher. Also, the rate for post-discharge complications, like infection, is higher in the myomectomy group. And there is some discussion about unusually high rate of infection in the UFI group, as Dr. Kumar has sent in his comment, which is which there is like no explanation for that yet. Next slide. So in the participant rating of the operation, uh, there was similar response for uh, undergoing the procedure in for both the UFI and myomectomy groups, and recommending to a friend. Next slide. The pregnancy outcomes, so in the UFI group, 8% of the patients were able to conceive compared to 4% in myomectomy group. which is a very important finding of this trial, as usually patients who want to have a child are usually not taken up for UFI due to risks of or decreasing the ovarian reserve due to non-target embolizations. Next slide. So the number of procedures required post UFI were higher, 16% as compared to myomectomy. However, there was it's interesting to note that in the myomectomy group, after the initial randomization in the myomectomy group, there were 7-8 patients who underwent hysterectomy initially, which could lead to some deviation in the numbers. Can you open the next slide?
Can you see it?
No.
The figure S1 compliance to treatment allocation by group?
Yeah. So 8 patients ended up undergoing hysterectomy in the myomectomy allocated group, which if we add up to the post procedure or to the need for re-intervention group, the rates would become almost similar in both the groups for re-intervention. Next slide. So there are some limitations which we discussed throughout the discussion. The rate of complete fibroid infarction in the study was unusually low. There was a high loss to follow-up, around 19%. There's lack of consistent embolization technique, as in the protocol, they did not specify the endpoints and the embolic agents used. There's an interesting bias which could be at play in this study, which is called inverse placebo bias, as the patients who underwent myomectomy underwent an open procedure, as 82% of them had an open procedure. They could think when we ask them to rate their symptoms, they will invariably think that they have a better outcome as compared to patients who underwent a minimally invasive UFI, where they just have a band-aid at the end of the procedure. Another limitation was that the severity of complications were not graded, and there was an unusually high post-procedure infection rate in the UFI group. Next slide. Basically, the authors concluded that patients who underwent myomectomy had better fibroid-related quality of life at 2 years versus myomectomy. However, from this study, I think a more appropriate conclusion would be that for symptomatic women with fibroid, both UFI and myomectomy have significant improvement in fibroid-related quality of life. Next slide. Do you want me to discuss the clinical case, or you want to take over?
Shrin, you want to take this one?
Yeah, sure. So at the end, we thought we would make it a little interactive and kind of ask the audience a question based on like the discussion so far. So the question is, a 32-year-old nulliparous woman comes to the office for evaluation of heavy menstrual bleeding. She wants to become pregnant the next year, and she's otherwise healthy, no surgeries. Pelvic exam shows an enlarged 10-week sized uterus, and TVIS reveals a introverted uterus with multiple submucosal fibroids. So which of the following would you recommend for this patient? Anyone that wants to volunteer or type in the chat, go ahead, and then we can kind of kick off a discussion from there. Any volunteers?
Why don't one of you guys answer?
Okay, so yeah, so we can kind of break down the question. So 32 years old, and she wishes to become pregnant in the next year. And then you also see the type of fibroid submucosal, which is very amenable to a hysteroscopic myomectomy. So in this case, because of these reasons, choice C would be the best option for this patient. Even though like UFI might provide symptom relief, because she wishes to become pregnant in the next year, it's probably not the best option for her. So we go to the next slide. We can kind of see what the ideal patient for a UFI might look like. So ideal patient would be post-childbearing, in 40s to 50s, perimenopausal. And the reason for that is there's still a recurrence rate for fibroids, regardless of kind of like what treatment you undergo. This is because like even if you cut off the blood supply to a fibroid, there's still blood supply to the uterus in general. So more fibroids can reemerge, or new ones can emerge, especially if the treatment's done at a very young age, like 30s. Perimenopausal because fibroids are estrogen dependent. With menopause, when you have low estrogen states, many fibroids will either stop growing, or they might even shrink in size and cause less symptoms. And post-childbearing, we kind of discussed it before, but
Yeah.
with UFI, when you limit blood flow to the uterus, there can be some effects on fertility and pregnancy outcomes. And also patient preference is a big factor. Some patients might not be great surgical candidates, so a more minimally invasive approach would be better for them overall. And Dr. Shulkla and Dr. Kumar, if you guys had any comments on this, or what your experience with UFI's been, what your patients are typically like.
Sure. Yeah. You know, Anthony mentioned earlier in his talk too that even if you get myomectomy at an early age where you scoop out a fibroid, this is an estrogen dependent condition. So every time you have your menstrual cycle, estrogen goes up during the first part, then goes down, and progesterone goes up, right? So when the estrogen goes up, the fibroids recruit lots of nutrients and get release factors like VEGF and stuff to recruit more arteries. So if you scoop out the fibroid, shut down the arteries, eventually over more cycles over the years, the fibroid can recur and other fibroids can happen, right? So in to say that you can't treat a 30-year-old woman with any of these procedures, you can, but to do a study to have different arms and see which patients have the highest rate of pregnancy is a very unethical study to perform. For now, my practice, and I can speak for Dr. Kumar as well, is that, you know, if they're very young patients, and we will not infrequently have, especially in our population in Newark, New Jersey, we'll get a young African-American woman who has a really strong family history, you know, mom, grandmother, aunts, all with fibroids. She's 30, 31, has one child or no children and still wants to have more kids. We, like Anthony mentioned, should proceed in a multidisciplinary fashion, talk to the patient, counsel the patient with the OBGYN as well, and give them their options. Now, recently I had a patient who didn't want any surgery, no scar, no nothing. She hasn't had kids, and she said, you know, I've really have researched all the different options, and I know, you know, fibroid embolization may not be the best thing for me, but I don't want surgery. I want to take care of my symptoms. If I have kids, then so be it. So that's where the patient preference comes in. So we actually treated her with fibroid embolization, really documented that we had this discussion with her. There have been retrospective reports recently published of women that have undergone fibroid embolization, and it actually improved their chances of pregnancy. You can imagine if the fibroids, the patient has a large fibroid that's actually impinging on the canal, you can have difficulty with embryo implantation. But it's not something that we can discuss as a definite comparison to myomectomy. So it is very, very important in these cases to proceed in the multidisciplinary fashion. For any woman that has had kids and does not have, and is in like the age range perimenopausal, I personally feel that hysterectomy or any surgical counterpart is very unethical in these patients, and that minimally invasive procedure that works just as well and has a 3-day recovery period should be the standard of care. And I'm sure all my IR colleagues agree with me. With that said, I'll let Dr. Kumar.
Yeah, just to kind of piggyback off what Pratik said, we don't have really like robust data on UFI and pregnancy post UFI, right? There are some reports where actually, as you mentioned, large fibroids that are not allowing for like a fetus to grow. There's reports that they've shrunk and people have been able to get pregnant, but then there's also reports of people losing fertility after UFI. So that's definitely something you want to discuss with your patient. When you see him in clinic, like do you desire future pregnancies or not? I think in terms of when making decisions of what to offer the patients, right? So definitely I agree when it comes to hysterectomy, I always tell my patients like, look, you can get a UFI, have some like minimally invasive procedure. Really, we do it radial. They leave with the Band-Aid. Complication rate is I'm gonna say like really under 0.5%, to be honest with you, in this day and age. You can always get a hysterectomy later, which is an invasive procedure, but you can't go sort of the other way, right? You can't you can't undergo hysterectomy, and there's significant morbidity with hysterectomies also. In terms of myomectomy, there was a trial that looked at myomectomy before this trial. It was called a FEMME trial, FUME, and it was published in CVIR in around 2012. And it was a smaller trial, and they looked at myomectomy versus UFI, and they actually found that quality of life improvement was the same, symptom relief was the same, but the UFI patients had shorter hospitalization and lower complication rates and things like that. So Tushar really pointed out some holes in the study. Really, the FEMME trial, a couple other things to add is just there was like one interventionalist, as we said, like 40% infarction rate seems pretty low. When you're doing a randomized control trial, you want to control for those things, and you want to get multiple interventionalists, maybe multi-centered study. Good presentation. If anybody has any questions for us, something you want to know about UFIs or general workup of these patients.
I did have a quick question about how long the hypogastric nerve blocks lasted and if you performed it.
Yeah, so hypogastric nerve blocks, so that's gaining a lot of popularity. I'll tell you personally, my practice, I do, most of my UFIs actually at our office-based lab, which is not in the hospital, it's an outpatient center. And I don't do hypogastric nerve blocks. I do, I do a radial approach. I do intraarterial lidocaine injection, which there's been studies showing that helps with pain. I do PO Tylenol before. I haven't had any need, to like send the patient to the ER, admit them, and they've had good pain control. But hypogastric nerve blocks are good. People kind of do it in the hospital setting. They sort of tie your patient over till they're discharged. So that's kind of like the goal to like, kind of get them home, but it's not going to last the following day. Like they're still going to need a prescription of Percocet. I just usually tell them, I like to do them on Fridays and tell them like, look, you're going to have a rough weekend, just kind of sleep, take the Percocet. You'll be good by Monday.
Okay.
I had a question. It was a great presentation, great discussion. What is your kind of algorithm of discussion in the preoperative visit about the pain and how to kind of navigate through that, as well as setting expectations for the pain, as well as what is your follow-up after your intervention, and how long do you follow them for, how many years, et cetera?
Right. So I can answer that, and then Pratik can answer that also after. So in terms of pain, when I'm describing, when we consult patients, I have like a little some of the diagrams and some of the pictures like Antony showed, I show them that. I, kind of go over the stuff, but I kind of tell them like, look, when these fibroids, they get all these nutrients from all these blood vessels, right? If you shut them off, you're kind of making them angry, and they get very angry, right? So as they're dying, there's a lot of crampy pain. It's kind of like really bad menstrual cramps. So I think if you set that expectation to begin with, and I kind of spin it almost as if like it's a sign that it's working, I think patients sort of kind of expect the pain and they're okay with it. In terms of follow-up, we do, we'll do like a telephone call follow-up the day after in a couple of days to see how they're doing. I usually see them in a month, just to kind of like see how they're doing. And 3 months after that, I usually, if they have good clinical response after that, I kind of just, don't have them come back. I just tell them like, look, follow up with the OBGYN or primary care. If symptoms occur, you can, follow up with us. If at 3 months, there's not good response, if they're still like, especially with the bleeders, still having heavy bleeding, I may consider doing another MRI. Did I miss some like, occasionally we didn't mention, but there's ovarian supply to these fibroids. I may get an MRI. I may think of a re-embolization, which is like at the 3 to 6 month point. But otherwise, I don't follow them, as opposed to like some of my oncology patient and stuff. You keep following them, for a long time. But I don't do that. People are following up to a year, kind of more for academic purposes, getting an MRI just to see how they did, what the infarction is. And I think Pratik's practice may be a little different than mine, so I'll let him speak about that. Pratik, what do you think?
No, I mean, I pretty much agree with you. So Abhi said, like, you set the expectations in the procedure consultation. What I tell patients is for the first up to 3 days, up to 72 hours, you're going to hate me. I'm going to be the worst person in your life. You're going to curse me out. It's going to be the worst menstrual cramps that you've ever had. I kind of give a similar analogy where I say, we're kind of shutting down the blood supplies to the arteries. And you can imagine when someone has a heart attack, the blood supply is getting shut down to their heart. So this is like having a heart attack in your pelvis. And when you set that expectation for patients, when we do the follow-up call the day after, I typically like to do my fibroids on a Friday because patients are off work on Saturdays and Sundays. So then we give them a call back either Saturday and then the Monday after, see how they're doing. And then typically when you set the expectation that it's going to be really bad pain, usually it's either that bad or not as bad. So then the patients actually really appreciate you being very honest with them. I do the same thing with partial splenic embos because those hurt really bad, and AMLs as well. Just let your patients know exactly what they're going to experience. Both Dr. Kumar and I have a rigorous algorithm that we give them for their pain management afterwards, including the post-op anti-inflammatories that we have the patients take. We do Toradol for the first 3 days and convert to Motrin. And we make sure we go over this in the preoperative consultation, the morning of before the procedure, and at the end of the day before they leave. Just because, we want to make sure they take their anti-inflammatories. They know that they have to take the narcotics we prescribe them if they need it. If they do take them, make sure they take a laxative, so on and so forth. As far as follow-up, I similarly follow them up, 1 to 2 months after the procedure, see how they're doing. We do a follow-up phone call, like I said, a couple days after, make sure the radial axis is okay. We do give them strict instructions not to do any heavy lifting. Look out for hematomas in the wrist. So we follow that up really quickly within the week. See them in person in a month. And then I do see them at anywhere from 3 to 6 months. And if they do have complete resolution symptoms, I personally do get an MRI. But like Dr. Kumar said, it is essentially for academic purposes. A lot of patients are reluctant to get it because they feel better. And long-term follow-up, at 1 year, 2 years, it's great theoretically. But a lot of these patients, as soon as they feel better immediately, after the 6 month follow, they're actually reluctant to follow up with you. They'll actually tell you themselves that, I'm doing well. I have my annual OB every year for my pap smear and my regular checkup, and I'll get back to you if we need anything. So that's sort of my practice as well. But I do try to follow them out up to a year at least.
Yeah, I mean, it's interesting. I've kind of shifted my pattern. So I used to do, when the fibroid registry showed a high recurrence rate, I started to follow it longer. I'd space it out, but I do about 4 to 6 week follow-up, then 6 month with an MRI. And I'm looking for if I have complete infarction, then I'm not as worried. But if I don't have complete infarction, I definitely will follow them longer. And then I actually space it out, maybe 18 months after that, so it'll be 2 years, and then maybe 2 years. And it'll be even a telephone visit just to see how they're doing. And I've caught a few patients that have recurred that have retreated. So if you look at all these trials, up to the EMMY 10-year data and the fibroid registry, not an insignificant recurrence rate. So rather than doing a hysterectomy, why not do a UFI in that 20%? That's rationale. It's a pretty quick follow-up, even a telephone discussion at this point with COVID. And it's because of EMMY's 10-year data, I follow them a little longer and before the 10 years. So I feel that's okay. And the question I have about the pre-op discussion, I wonder if what that discussion was and by whom in the European trials. Was it done by the interventionalist? Who was doing the follow-up? Was it the interventionalist or someone else? That also plays a big part in the patient's experience, their Q of L score. So I wonder about this and that to the group.
Georgie, how often are you seeing incomplete infarction in the 6-month MRI? I mean, I get a 6-month MRI usually too, as long as the patients are up for it. A lot of times the patients that are reluctant, but I think one patient in my short career as an attending, I saw that I had incomplete embolization. She did have really large fibroids and didn't have uterine supply at the time. If they're really large and they go up, above like the pelvic brim, I'll actually do an aortogram, and I didn't see anything at that time. And we repeated the embolization for her. But I haven't encountered much incomplete infarction in all my other patients. I think we lost him.
Yeah, I think we lost him. Yep.
Anybody else have any questions for us? Then any students?
Yes, I have a quick question about pregnancy post-UFI. You mentioned that there's not a lot of like robust data on it, but I was wondering if you are familiar with any data or any like case reports or suggestions about outcomes in the neonates from patients that have had a UFI, such as like rate of prematurity or any other fetal or neonatal complications.
There's some retrospective studies that have shown that it's possible to be, to have viable pregnancies afterwards. I don't think they followed up or mentioned too much. I mean, I know there was no difference in prematurity, but they didn't really mention the neonatal complications off the top of my head that I can think of. I mean, if you think about it, right, like you're not doing the UFI, like why would you have a neonatal complication? I mean, if your uterus is still viable, can implant a pregnancy, it's usually years after the UFI, so shouldn't really have any complications.
Yeah, and I think you're right. I think like the data that's out there hasn't been clear cut as to, from the prospective trials that patients have definitely gotten pregnant, and it's not clear cut whether that means. The only data we have comparing UFI to myomectomy in a kind of randomized fashion is the MARA data, which suggested that myomectomy may be better for fertility. But it probably needs to be repeated in the US. And I wonder if we should do a US trial looking at myomectomy versus UFI using kind of, our kind of algorithms of follow-up and our preoperative discussion, because I think that has my bias is, we've got the kind of pain algorithm down. Whereas if you look at the EMMY, it wasn't the interventionalist kind of man perioperatively or following them. So I wonder if the outcomes would be fundamentally different in our hands with the preoperative discussions that we have and the fact that we're following those patients longitudinally.
I definitely agree, George. I think the US, I mean, the US data we have is like mostly from that registry, right? Like Speech published in 2005, I think it was. Yeah. So
yeah, the 1 year and 3 year data.
Yeah. So I mean, I think it's about time that we sort of jump into this and do it. the question is to just kind of, it comes under collaboration with, OBGYNs willing to do the, one-to-one randomization. I think that would probably be the biggest challenge to get a center that will do that, right?
Yeah, but I think there's enough patients coming to us for fibroid therapy. They're reaching out on the internet and the fibroid.com and all of these different things. I think we could certainly enroll patients just for those that come to us now, directly, right? They're told no other options, and they come and see it on the internet, or Condoleezza Rice had it, and so on and so forth. So I think it's becoming more and more compelling that this is a definite option. No, but it's definitely one of the. I think it was a great kind of discussion, and I think this is definitely an option that patients should be offered. The challenge is when you have a hammer, everything's a nail. Or so if I'm the interventionalist, we're gonna be biased to promoting this, right? Whereas if you're a surgeon, a gynecologic surgeon, you're gonna look, you have a 30% recurrence rate, and it's very painful. So it all depends on which side of the aisle you sit on, and there's probably truths on both sides, is my thought, But I think with your pain regimen, the fact that you can do it outpatient, they recover in 3 days, they're not even hospitalized, their bounce back to work is much more rapid. I think those are all things that patients want to know about, or should know about.
Yeah, definitely.
I was just wondering if you ever faced an issue where like social determinants may have led to any complications or an increase in the rate of complications or associated. I'm wondering, just like not being able to reach out to your OBGYN or your interventional radiologist to talk about the symptoms that you might be having after the intervention. I don't know. I'm just thinking out loud, but just wondering.
Yeah, there's definitely in terms of awareness, there's a lot of campaigns across the country, just fibroid awareness, presenting it as an option. So that, access to healthcare is definitely, just like anything else, that's an issue. And I'll tell you from a sort of urban center in Newark, New Jersey, that's definitely an issue, just like with everything else. But I think we're getting a little bit better. I think the IR community is getting better about, direct patient outreach, kind of, educating patients and, even primary care providers about, having access to this kind of procedure.
Yeah, I know Shulkla and Kumar have done a great job at their program of really kind of doing the right way by seeing marketing, branding themselves as clinicians, and following their patients in an appropriate fashion. So I think they're kind of a prime example of the kind of the future of our specialty and the modern day way of appropriately taking care of patients. So kudos to them.
Thanks, Georgie.
Thanks, man.
Anything else? Great job, guys. Just want to say, all three of the presenters and everybody participating, you guys did an awesome job. You're way better than when I was a medical student, I can say that. But I hope everybody learned something. And
yes, it's a cool effort to do this internationally also. It's pretty cool. Yeah. I think now, especially in these times, Zoom seems annoying now, but it's so amazing that we can connect all over the world and do this forget about different time zones in the US, but in different countries. So yeah, really good job, guys.
All right, thank you.
Take care. Thank you so much.
Thank you.
Yeah. Have a good night, everybody.